In this vlog, we look at deprescribing. The need for deprescribing is particularly prevalent for the frail elderly, people in minority ethnic groups, and those who are vulnerable. Overprescribing is one reason why a medicine may need to be deprescribed. If medicines are overprescribed, this affects the patient's experience of and engagement with health and care services. It results in unnecessary costs and harm to patients. This is a whistle-stop presentation linked to the latest information and research. This is the core material, a paper by the Department of Health and Social Care in England, which was published in September 2021. So what are the causes of overprescribing? Here are some of the causes. The use of single condition guidelines for patients with multimorbidity, particularly when there are multiple prescribers working in different specialties. A lack of alternatives. A patient pathway that doesn't include regular medicines reviews or specific consideration of deprescribing. The inability to access up-to-date full medicines record for the patient. Medicines recorded on separate and incompatible systems which may be held in different organisations or by different specialties. The absence of a full and detailed medication history, including what worked and what didn't work in the past, what side effects were experienced, any adverse reactions experienced, and the effect of as required PRN medication. Pressure of time, which can apply equally to the clinician and the patient, and the culture of prescribing medicines over possible alternatives. There are some underlying factors why medicines are said to be overprescribed, which explains why this problem is not as simple as just looking at the medicines chart and crossing things off. These include age, frailty, ethnicity, minority and migrant groups, deprivation, vulnerable groups such as people with mental illness, learning disability, autism, cognitive and sensory impairments. Assessing mental capacity at the time of prescribing and administration is also critical here. This is covered in more detail in the previous vlog. So why are actions to reduce overprescribing important? Here are 3 reasons from the report. Firstly, at least 10% of prescriptions in primary care may not have been needed. Secondly, adverse reactions, ADRs, are thought to occur in 10 to 20% of hospital admissions, and the person taking 10 or more medicines is 3 times more likely to be admitted to hospital because of an ADR. Thirdly, a study showed that in England in 2019, 3.8 million people were taking 8 or more unique medicines. These figures don't take into consideration medicines that are prescribed and not taken, or indeed medicines that are prescribed and diverted, that is, they are passed on or sold to somebody else. In some cases, widely prescribed medicines may never have been needed in the first place. I've come across cases where long-term depot antipsychotic medicines has been stopped and it has been found that it was no longer needed. In one case, when we looked through the notes, it was difficult to ascertain the original indication for the prescription. So what is deprescribing? Here are some definitions. Firstly, here's a generic definition. Deprescribing is the process of intentionally stopping a medication or reducing its dose to improve the person's health or reduce the risk of adverse side effects. For polypharmacy, there are several different definitions of how many medicines constitutes polypharmacy. The World Health Organization lists this as 5. What's especially important is that there are 2 types of polypharmacy, as this paper from the King's Fund explains. That is, there is appropriate polypharmacy and problematic polypharmacy. I know from my own experience as a mental health prescriber that sometimes polypharmacy is necessary. For example, when it's been carefully proven to be the most appropriate and safest approach, and where alternatives have not worked. The most important consideration is the effect on the patient, that it is their choice and their involvement in the prescribing process as part of a shared decision-making process. Thirdly, on definitions, the current definition of a structured medicines review is important, often referred to as an SMR. These are described as evidence-based and comprehensive reviews of medication, taking into consideration all aspects of the patient's health. In an SMR, patients and clinicians work in equal partnership, taking into consideration the benefits and risks of taking the medication and alternative approaches. Since 2020, all primary care networks have had to identify patients who would benefit from a structured medicines review. In particular, people in care homes, people with problematic polypharmacy, that's 10 or more medicines, frail, isolated and housebound people and those prone to falls, and people using potentially addictive pain management medication. The NHS information also adds that a number of patients who can have an SMR will depend on the primary care network's clinical pharmacist capacity. There are, of course, areas where a structured medicines review can and does take place outside of the primary care. An opportunity to expand the number of prescribers and the relevant skills will increase this. Plus, community pharmacies in England can follow up and support this process through the New Medicines Service, referred to as the NMS. What works and what's happening to improve deprescribing? The Department of Health specifically mentions 4 areas on this slide: shared decision making, better guidance and support for clinicians, more alternatives to medicines, and structured medication reviews. We covered shared decision making in vlog number 1, so I'll move on to talk about better guidance and support for clinicians. Much of my work in patient-led care revolves around alternative to medicines and social prescribing. Social prescribing happens with link workers in primary care networks who provide an opportunity to share what's available with patients and support them to come forward and take part in non-medical activities. It's worth reflecting on structured medication reviews. What happens in your specialty and your area of work? Who delivers these reviews and how do patients access them? What does the Department of Health and Social Care review propose? The review proposes 3 areas of change: systematic changes to improve patient records, transfers of care and clinical guidance to support more patient-centred care; culture change to reduce the reliance on medicines and support shared decision making; and a new national director for prescribing. There are also a wide range of specific recommendations in the report, one of which is that the Royal Pharmaceutical Society should revise the prescribing competency framework to take account of the review findings, including the increasing number of remote consultations. On a personal note, I was disappointed to see that the idea of an overarching national body on prescribing that would bring these recommendations together is not in the report. Where can we find resources to help deliver safer and more person-centred prescribing? There is some useful information and resources on the Australian Deprescribing Network website. There are also useful resources on the Canadian website deprescribing.org. Of course, when looking at these, you need to bear in mind that the laws, guidance and medicines names differ between countries. There's also a good resource to help with deprescribing at medstopper.com. This resource allows you to put in the name of a medicine for advice on deprescribing, particularly relevant when it comes to tapering a medication. This is a useful, practical and accessible tool that is freely available to everyone. So that was a quick run through of some of the useful information and resources in relation to deprescribing. Here are just some examples of ways to reduce unnecessary medicines. Here are some questions for reflection. Which of these are used in your area of practice? What is missing from this list? What other things should be on this list? If you were able to implement a change in practice in your area of practice, what would it be? What would the benefits be? How would you measure the benefits? I hope you found this vlog useful. You can find a template for reflection here. It may be this can be used for appraisals, peer reviews, or to go towards revalidation. We welcome your feedback. There's a short 3-question survey listed in the links section.